Hello, good morning, all. Can you hear me? If you can hear me, please just wave your hands. Let me be
Yeah.
sure.
Yes. Good morning, sir. We can hear you, sir.
All right. Thank you very much,
Good
and welcome
morning.
to today's.
Morning, sir. We can hear you.
Good morning. We can.
So today, my name is Prosper Onyekachukwu. Your regular host, and it's nice to have you again on today's Tele Eco session. We'll be looking at another interesting one today on intimate partner violence. We have one of our renowned subject matter experts already standing by to talk to us. But before then, I'd like to ask that all the participants please turn on your video, especially if you're a facility or individuals, as much as you can. But for facilities, please, it's a must for you to turn on your video and then name your facility properly so that we can identify you as well. We'll be looking at, okay, let's have representative from Federal Ministry of Health to give us an opening remark. We have Dr. Ganiyu Jamiu, who is the head viral hepatitis component at NASCAP, but I can't see you, Dr. Ganiyu. So if you are not there, maybe we can have Labake Ikunda, please stand in for you. Labake, please let me hand it over to you.
Okay, thank you, Prosper. Good morning, everyone. You are welcome to another exciting and impactful ECO session this morning. I would like to welcome our subject matter expert for today, Prof. Eugenia Ofondu. Thank you, Ma, for being on the call today. And I believe at the end of the session, we'll all have, a robust and successful session. And also, I would like to appreciate all our participants. Thank you for being on the call this morning. I also welcome the CDC representative and also the Phase 3 team. And today's topic, as Prosper Adelia mentioned, that it's on intimate and partner violence. And we all know that it's one of the most common forms of violence against women, and which includes physical, sexual, and emotional abuse. And the causes, the types, all this will be discussed here this morning. And I believe Dr. Ofondu will do justice to this topic. So I welcome you all once again on behalf of the Federal Ministry of Health and the leadership of NASCAP, Dr. Adibobola Basharu, and wish every one of us a successful session. Over to you, Prosper. Thank you.
All right, thank you very much. I don't know, yeah. Can you all hear me very clear?
Yes, yes.
Okay, all right, thank you very much. So let's have a representative from CDC, the person of Mrs. Bukola Adewumi, who is CDC Gender Program Specialist. I can't see you. If you had joined in with a different name, please can you raise your hands? Let me enable you to speak. Mrs. Bukola Adewumi from CDC, or any CDC representative, if you are here, just kindly use the Zoom platform to raise your hands and I will enable you to speak. All right, in the absence of that, I will go straight ahead to invite the subject matter expert. Like I said, we're looking at intimate partner violence, and we'll have one of our finest subject matter experts, Dr. Eugenia Ofondu. Dr. Eugenia Ofondu is a consultant dermatologist. She's also a genitourinary physician and HIV manager at Federal Medical Center, Owerri. Dr. Ofondu, please, can we have you go on with your presentation?
Thank you so much, Prosper. Good morning, everybody. Special thanks to Labake for the introduction and also to the Phase 3 team for setting us up this morning. I also want to welcome all the participants, the SAPCs, the facility staff, the national and state clinical mentors, and any other healthcare providers that may have joined us today. So today we will be looking at intimate partner violence. Next slide, please. This is our module 4, and our learning objectives after completion of this module, next slide, we would aim to look at 3 specific sections. Number 1 is to understand the gender dynamics in the context of index testing services. Number 2, to build the skills we need for routine inquiry and screening for intimate partner violence as part of our index testing strategies and partner notification services. And number 3 is to identify the strategies we need to address the risk of intimate partner violence in index testing and partner notification services. So let's remind ourselves that index testing is part and parcel of the spectrum of differentiated HIV testing services. And remember that there are 4 partner referral options, 1 being the client passive referral option, 2 being the provider active referral option, 3 being the contract referral option, and then of course 4 being the dual referral option. So for those who have been following this series, you would know what I'm talking about, these 4 partner referral options. Next slide. But we want to focus, next slide, please. We want to focus on intimate partner violence, okay? And its importance when we're doing index testing. So how do we define intimate partner violence? Simply put, it can be defined as physical, sexual, or psychological harm by a spouse or a significant other. And it refers specifically to abuse within an intimate relationship. So you find out that the vast majority of survivors of intimate partner violence are women who may suffer various types of violence, such as physical, sexual, emotional or psychological abuse, financial violence, or controlling behaviors. It's important for us to note that up to 30% or more of women worldwide have experienced physical or sexual violence, mostly by an intimate partner. And in countries like ours, Nigeria, the reportage would be low based on our socio-cultural norms. So 30% may be the tip of the iceberg for us in this country. Next slide, please. So what is gender-based violence? Next slide. So gender-based violence is actually an umbrella term for any harmful act that is perpetrated against a person's will. Prosper? Good. That is, so gender-based violence is actually an umbrella term for any harmful act that is perpetrated or carried out against a person's will and is based on socially ascribed differences between males and females. And we can see that intimate partner violence is actually part and parcel of gender-based violence. So it is a subcategory under gender-based violence. Other categories would include sexual assault, physical or psychological abuse, threats and coercion, arbitrary deprivation of liberty, child sexual abuse, and economic deprivation. So gender-based violence is much broader than intimate partner violence, which is a subcategory of gender-based violence. Next slide, please. So I just want us to look very briefly at the UNAIDS targets. Next slide. You'll wonder why I'm going to the UNAIDS targets, but let's remind ourselves of the 95, 95, 95. 95% of people living with HIV know their HIV status, and 95% of these individuals are receiving ART, and 95% of those on treatment are virologically suppressed. However, the importance and the impact of gender inequality cannot be negated. Gender inequality is actually looked at in the Sustainable Development Goals number 5, and it has impacted negatively on HIV programming and other developmental programmings worldwide. So therefore, the UNAIDS targets were broadened and increased to look at the additional UNAIDS targets, next slide, which actually addresses gender inequality and gender-based violence. So if you look at this slide, you will see that in the center of that circle are people living with HIV and communities at risk of HIV. It recognizes the fact that we cannot program for PLHIV without looking at their communities. And it also extends the 95-95-95 to also include combination prevention strategies and also lay emphasis on vertical transmission of HIV. But if you look beyond the inner circle and look at the outer circle, globally, these additional UNAIDS targets need each and every country to focus to ensure that less than 10% of individuals experience gender inequality and violence. So you can see the importance and the emphasis that is being placed on gender-based violence. Next slide, please. So violence against girls and women occurs at every age and stage of life, starting from when they are children with child sexual abuse, to early forced marriages, to honor killings in certain countries, especially in the Asian countries, trafficking of women and girls for exploitation, sexual violence, and of course, the huge elephant in the room we're looking at today, intimate partner violence, which we've already mentioned occurs globally in more than 30% of women. Next slide. There are consequences to intimate partner violence and gender-based violence. We've mentioned that there are several types of this violence, and the three major ones are physical, psychological, and sexual. Physical gender-based violence can lead to the individual picking up sexually transmitted infections, of course, HIV included, and also unintended pregnancies. Psychologically, the consequences of gender-based violence or intimate partner violence can lead to shame, to depression, to insecurity, guilt feelings, post-traumatic sexual disorders, and in some individuals, suicidal ideations. Socioeconomically, gender-based violence can lead to feelings of exclusion, family rejection, and loss of resources. But it's important for us to note, having highlighted that one of the physical consequences of gender-based violence is HIV, that HIV and gender-based violence are a syndemic. Living with HIV is a risk factor for gender-based violence, and gender-based violence itself is a risk factor for HIV transmission. It's important for us to note and understand that intimate partner violence is a predictor of poor outcomes for recipients of care because it adversely affects retention in care, adherence to therapy, follow-up visits, mental health, and ultimately viral suppression, which we'll see at the end of the presentation. But it's important for us to know that people who are living with HIV and those at high risk of acquiring HIV should be screened for intimate partner violence where appropriate, because the two, it's a bidirectional relationship. And this is captured again in what we call the SAVA syndrome. Next slide. So the SAVA syndrome is an acronym for substance abuse, violence, and AIDS. And this terminology was coined by Singer et al. In 1996. It simply highlights the fact that intimate partner violence and HIV infection are entwined extensively. There's a synergistic consequence of substance abuse, violence, and AIDS, with a relationship whereby one increases the burden of the other. So those who are abusing substances are more likely to expose themselves to acquiring HIV. And HIV infection and the stresses that go with it are more likely to increase substance abuse in certain individuals. Those who find themselves living in violent situations at home or with an intimate partner are also more likely to have a higher prevalence of HIV acquisition. Next slide, please. So what are some of the signs and symptoms? What should we be looking out for when we're in the clinic, when we're seeing clients? Be these clients those that present for testing, in which case we're doing index client referrals, or be they old clients who are presenting for their drugs and consultation. As healthcare providers, we should be alert to clients who present to us for repeated consultations without any apparent reason. So you saw a client last week. The client presents again within a few days, not to collect drugs, and has no reason for coming to the clinic. The client may be anxious. The client may be withdrawn or overtly aggressive for no justifiable cause. The client may be depressed or complain of chronic pain that you cannot pinpoint or put your hand on. The red flags on the right are the ones that we have to be very alert to, because they signal an emergency situation which requires intervention as fast as possible. And these are wound or punch marks or injuries, a refusal to state how these injuries came about, a partner who comes to the clinic with the client and is overtly attentive or controlling and insists on knowing everything about the client and does not even allow the client to be seen confidentially. Physical injury seen in pregnant women, or a history of attempted suicide or suicidal thoughts. And of course, a delay between the time an injury occurred and seeking treatment for this injury. All of these are red flags which we must respond to as fast as possible, because it increases the likelihood that the client's life may be in danger. And if it is a pregnant woman, both mother and the unborn child. Next slide. But before we can respond to cases where we think there's intimate partner violence, there are certain minimum requirements that we must have in place. Number one, it's important that we realize that we should know how to go about asking about intimate partner violence. And when we do ask, the response that we need to give and the support that we can offer, all these must be clear-cut to us. So there should be a written protocol or SOP for the provision of violence response services in place. We should have a standard set of questions we're looking at and ensure that any documentation we make on this is secured in a safe place. All this should be occurring in a confidential area where the client is likely to open up to us. And depending on what transpires, we should also have the details ready for systems for referrals to ensure that the person can be linked up to support systems beyond the facility if the need arises. The box that you're seeing, 1, 2, 3, the fourth and the fifth items are what we're dealing with today. We want to ensure that providers are trained on how to ask about and respond to intimate partner violence. And we're going to use the acronym LIVES to do this. So next slide, please. So when you're looking at bringing up the issue of intimate partner violence, you must have an intro to the topic. And these are some suggested scripts as to how you can introduce this topic to a client. You want to ensure that you're caring about the client's well-being, and you want to support them to decide whether index testing is right for them, and if it is, how it can be safely done. So a good intro would be, as part of index testing, I would like to ask whether each of the people you named has ever harmed you in any way. This is important because it will help us decide together whether index testing could be safe. It is also important because I care about your well-being and can help connect you to services. So you can see the sample script also shows the client that you care about the client, and also makes it evident that you will be mindful of the client's well-being no matter what. So having gotten a list of partners from this index client, you would go ahead to start asking questions for each client, one after the other. So let's look at how we would go about that. So you want to ask whether the partner has ever hit or kicked or slapped or otherwise hurt the index client. That's the next slide. You want to ask whether the partner has ever forced the client to do something sexual that made him or her uncomfortable. You want to ask whether the client has been controlled by this partner, okay, or whether the partner has ever humiliated the client. And in cases where you're dealing with K-pop, okay, and transgender, you want to also ask whether they have utilized gender orientation to actually threaten the client, or whether they've even tried to stop the client from doing certain things in relation to his or her gender identity. So that would be an intro. If the individual says no, which is the next slide, if after asking all these questions, the index client says no, next slide, please, then even if you suspect that this index client is undergoing intimate partner violence, accept their reply. Do not force them or try to put it to them, I know you're lying, I know that's not the truth. No. However, you should let them know that you are here. And if at any point in time they wish to discuss this further, or they remember any incidents or anything happens in the future, you are here, okay, to listen to them and to counsel them. Remember that socioculturally, it's not in our norm to discuss intimate partner violence. And many people who come to the health facility are not expecting questions about violence. So they may not come prepared to talk to you about this. However, if they go back home and they think about it, or there's another incident, they may choose to come back and describe their experiences to you. And as at that time, you have an opportunity to impact on this individual. If, on the other hand, having asked some of these questions, the index client actually admits to intimate partner violence, what should you do? So let's look at the next slide. So, number one, right? It's important to identify each and every partner that the index client has listed separately. So if an index client has given you the names of 5 partners, you should take them one after the other. So if the first partner listed The client said, yes, there's intimate partner violence with this person, right? It does not disqualify that partner from index testing, okay? But it's important for you to know whether it is safe and which particular modality would be preferred by the index client. Knowing fully well that if you don't address these issues of intimate partner violence with the client, it can affect treatment adherence, it can affect viral load suppression, and of course, his or her overall well-being. So you need to respond immediately with first-line support. You need to be able to sit down with this index client and draw up a safety plan and a social support map, right? With a roadmap and partnerships that support the specific needs of this individual. And how do we do that? We do that by using the acronym LIVES, L-I-V-E-S. Let's look at the next slide. So LIVES is the acronym we use as a form of psychological first aid. And it looks at providing first-line support to somebody who has accepted that he or she is in a relationship with intimate partner violence. The L stands for listen. Listening closely with empathy and non-judgmentally. The I stands for inquiring about the needs and concerns of the individual, be they emotional, physical, social, or safety needs. The V stands for validating their experiences and showing them that we believe and understand what they told us. And then the E stands for enhancing safety. And the S stands for providing support and connection to additional services that may be required. Next slide. So let's start with the L, listening, the do's and the don'ts. I'm not going, essentially, it looks at good communication and listening skills. But the most important thing we need to notice here is that our role is to listen to the client and understand what they wish to do without attempting to direct them towards a specific choice. So we need to respect the client's wishes, and we do not need to think and act as if we can solve the client's problems. L, listening to the client. How do we inquire? That is the next slide. How do we inquire about needs and concerns? Next slide. So there are techniques and questions we can use as an invitation to the index client to talk to us. And in doing this, we're asking open-ended questions that encourage the index client to speak, such as, what would you like to talk about? And how do you feel about that? We want to check and be sure that we understand what the person has spoken to and reflect back and explore as much as required. Again, good communication skills. And eventually we want to summarize what the index client has expressed to be sure that clearly we got the message correct and any misunderstandings can be corrected. So we've looked at listening, we've looked at inquire, L-I. We're moving on to the V, which stands for validation. Next slide. The purpose of validation is to let the survivor know that their feelings are not abnormal, are not uncommon, and that it is safe for them to express themselves. And just like everybody else, they have the right to live without violence. So they need to know that the situation they are living in, a situation of violence, is abnormal, and they have the right to live in a normal, non-violent manner. V. So we've done the L, we've done the I, We've done the V, which is validate. We're moving over to what? The E. E stands for what? Enhance safety. In this, while we can't guarantee the survivor's safety, we can try to help them stay safe. So in enhancing safety, we want to assess the survivor's situation and make a plan for their future safety. And we can do this by looking at safety strategies. Next slide. Safety strategies. So you want to look at what is available in your state, in your environment. Do you have emergency shelters? In Lagos, there are shelters for the homeless. There are shelters for the abused. Do you have an agency that deals with domestic and intimate partner violence, like the Domestic and Sexual Violence Agency? Do you have NGOs that are willing to assist people in need like this with financial assistance and otherwise? So if you have all these, you would have all this information already. You would have identified where these services can be gotten, and you would be able to provide the details of how this index client can access these services. But it's important, a note of warning on the right, we shouldn't tell our index clients how to stay safe. It is a conversation, okay? And we should offer what is available. It is left for the client to say, this is what suits me. Next slide, please. So we've done lives. We've listened, we've inquired, we've validated, we've enhanced what? Safety. And now we want to provide support, the S in lives. The purpose of providing support is to ensure that we connect these survivors to resources within and outside the health facility that will look at their health, their social, their justice and legal needs, and any other needs that are beyond the healthcare provider that is speaking to this client. So it's important that we respect the person's choices and are non-judgmental when we're doing this. And we also apply rule number 1, which is what? Do no harm. So we will support this index client to remain alive until they are out of the violent situation, while respecting their choices and not judging the actions or lack of action that they choose to make. So please, let's remember rule number 1. Do no harm. Do not impose your thoughts, your suggestions on clients with intimate partner violence. However, respect whatever choices they make based on what you lay before them. Options. So let's go to the next slide. The next slide kind of brings together all the services that may be needed. The services may be physical and mental health services, quite a lot. If the person has been injured, the person may need emergency treatment. The person may need prophylaxis for STIs, okay? Treatment for STIs. The person may need prevention against pregnancy using Postinor 2. The person, if the person is going to court and requires legal evidence, may need to have forensic examination to present. There may be the need, not maybe, there will be the need for mental health screening and treatment for depression and post-traumatic stress disorder. Mental health evaluations should be in our environment, and again, are not socioculturally acceptable to a lot of people. Because once you mention mental health, it's like, oh, do you think I am mad? But it's important to realize that living in a scenario of intimate partner violence is mentally traumatic, and that individual will need mental health treatment. So the social services that need to be provided will differ based on the varying situations. If you have somebody who has been trafficked and doesn't even speak the native language or English, you may need an interpreter to get across to the person. The person may be homeless and require not just shelter, but also food assistance. The person may be out of school because they've been thrown out of the house. The person may have left with his or her children and need childcare. So social services will also differ based on the scenario that the index client with intimate partner violence presents with. And of course, for those who accept legal or justice services, it's important for them to understand their rights, which particular law enforcement agencies that they can use, and the support they will get from these agencies. And they may need assistance to give a statement or to seek redress. And if they are actually already in prison, it's important to ensure that they're getting their ARVs. So our job is to make sure that we have information on where all these services can be gotten. And we have details as to how these services can be acquired. So we should also already have a relationship with certain service providers like FIDA, the Federation of International Women Lawyers, who provide free services. The police, there's usually a desk in every police station with a desk officer that deals with violence. And you can choose whom you think you can work with on a facility-to-facility basis that you can liaise with. If most of your IPV patients are women, as it is in most cases, you may choose to have a relationship, an ongoing professional relationship with a female police officer who is willing and able to respond, either when you bring cases to her or when she is requested to come to the facility to see a case, as the case may be. So it's important to know and establish these relationships and have contact numbers. So next slide. So some of the immediate clinical services that we spoke about, two major ones: post-exposure prophylaxis for those who are not HIV positive. So if someone has been exposed to HIV, either through rape, you would need to begin post-exposure prophylaxis within 72 hours. And we've had sessions on Spice Echo to exposure prophylaxis. Pregnancy, it's important to ensure that emergency contraception is started, usually within 72 hours if we're using Postino 2. But if possible, will increase the efficacy of Postino 2. Next slide, please. So while you're looking to provide support, it's important to be sure how this support is provided. If you are offering printed information or writing down numbers for an index client with intimate partner violence, it's important to warn that if the materials given come to the attention of an abuser, it may spark a bout of what? Violence. It's also important to know the specific information to give about where you're referring the index client to, and ask whether the index client wants to be accompanied to these resources like the police or to FIDA, or whether they would prefer that these resources come to them while they're in the facility, or whether they would go there on their own when they want. But it's important that when we offer this, we allow the client to take an informed decision and ensure that we stick to rule number 1, which is do no harm. You also don't want to pressure clients who have intimate partner violence situations to accept a referral or give details about an incident if they don't want to. Like we said, if they say no accept the no and ensure that they know that you are still available in the future to continue to discuss these scenarios and offer assistance. I'm going to end by looking at the spectrum for HIV care. Next slide. The spectrum looks at 95, 95, 95, okay? But it also reminds us that there are potential links between intimate partner violence that cut across the HIV care continuum. So you find out that women with a history of intimate partner violence are less likely to even come for HIV testing. So it reduces the number of women with intimate partner violence that are likely to be tested and fall into our first 95. And even when they are tested, linking them to care is a problem, because one of the major barriers is what? Disclosure. They may not want to disclose to their spouses because they may feel this may trigger intimate partner violence or may actually start a cycle of abuse. Even when they're linked to care, their adherence to treatment and adherence to follow-up is poor. And because this adherence is poor, the likelihood of viral suppression is also reduced. So intimate partner violence cuts across adversely on the entire HIV care continuum, from testing to linkage to retention in care to ART adherence, and lastly, but most importantly, virological suppression. So while we're looking at ensuring that we identify those who have intimate partner violence when we're seeing clients newly, it's important that we remember that even our old clients, we should be on the lookout for intimate partner violence, using the signs and symptoms we talked about, and assess those who meet those criteria for intimate partner violence, because that may be one of the factors that has led to virological. Next slide. Understanding gender dynamics in the context of index testing services is one of the things we have addressed today. We've also looked at the common signs and symptoms of intimate partner violence and how to conduct a routine inquiry for intimate partner violence as part of index testing. We've looked at the strategies for addressing the risk of intimate partner violence, how to plan for safer HIV disclosure using the acronym of LIVES: listening, inquiring, validating, enhancing safety, and of course, providing support. Thank you. The references are in the slide below. Thank you very much. Over to Prosper.
Thank you very much, Dr. Eugenia, for this wonderful presentation, well detailed, and I hope all the partners are learning, and I know that there's no intimate partner victim among us here. Thank you very much, Dr. Eugenia. Before I go on, we missed out an introduction from a CDC representative. We have from U.S. Center for Disease Control, Nigeria, Mr. Bukola Adewumi, who is CDC Gender Program Specialist. I would want to know if you have one or two things to say before we take in questions. We also have one of our renowned subject matter expert, Dr. Yetunde Akani, a counselor. I think this also is a key area. So, but let's have Mrs. Bukola Adewumi first. Mrs. Bukola, over to you now.
Thank you so much for the kind introductions. And thank you so much to our presenter, Dr. Eugenia. You did a wonderful job. The presentation was very clear and direct. Thank you so much for the beautiful presentation. I just have a few things I want to highlight. Please confirm you can hear me clearly.
Yeah, we can hear you. Go on.
Okay, so the first thing I want to highlight is around the rule number 1, which is do no harm. Now, in conducting IPV risk assessment, that is one key rule which Dr. Eugenia has stressed, and I want to further stress it. Now, the minimum requirements for routine IPV inquiry has to be upheld in all our facilities. If you do not have those minimum requirements in place, you should not even be conducting IPV inquiry, because you'll be doing more harm than good. Because if you don't have the necessary requirements to conduct IPV inquiry, you would be doing more harm and denying a lot of people the adequate resources and help that they should be getting. So please, I want to say it again. If you do not have those minimum requirements in place, you have no business conducting IPV inquiry. And if you do, and you do not have the tools in place, please reach out to your support teams. They have the necessary tools that you can utilize in conducting IPV inquiry and screening. Now, to further highlight how IPV impacts clients from achieving viral suppression, I want to give it to Dr. Eugenia again. She did a great job. I want to just share one data that we gathered. Very recently, we gathered data from about over 10 or 20 of our facilities, just to understand how IPV impacts patients in achieving viral suppression. And we saw that from the data that we gathered, almost half of all the clients screened positive for IPV. So it is a serious matter, and it's something that we should please always conduct routinely in our facilities, because we have to help people. People are going through a lot when it comes to IPV. We have to ensure that we help them and provide adequate resources. Now, if you need the trainings, if you need the guidance, we have many people that are skilled in all your supported states that can help in ensuring that you get all the tools and all the help, the trainings, the resources that you need. We are not short of them. So please reach out and we will get you all the help that you need. I saw a question in the chat, and I'm hoping that Dr. Eugenia would respond to that. So thank you, and that's over for me. Over.
Thank you very much, Mrs. Bukola Adewumi, and thanks to CDC for all your support on this project and beyond. Again, we want to open up the floor for questions. We have also on the floor Dr. Ganiyu Jamiu, who is head viral hepatitis component at NAFTA Division of Federal Ministry of Health. I think we will usher him in during closing remarks. If you have other contributions to make, then we'll be glad to have you speak. So do we have questions, facilities? Already I have one that I want Dr. Eugenia to respond. So talking about intimate partner violence, you know, it's usually very difficult to define among married couples, especially when you know, trying to have relationship and all of that, and then one party is not interested, and one party feels it is his or her right to get that. How do you define? Is there any right for those that are married to actually, for someone to seek redress when there is some kind of violence among married people? Dr. Eugenia, would you want to quickly respond to this?
Thank you, Prosper. I think Yetunde is on the call, but I'll say the bit I have to say. And I also want to thank Bukola for all the wonderful comments she made and the highlights that she brought to the fore. If you notice, I kept on saying social-cultural, because intimate partner violence is something which the way you handle it may differ from one country to the other. You've brought up a social-cultural issue, which is married couples. In some parts of the country, it is actually deemed that, oh, intimate partner violence is no big deal, right? And one member of the couple should just, bear it if intimate partner violence is there, oh, it's a norm. It's part and parcel of what you should expect with marriage. And being careful not to say female, because intimate partner violence can also occur to males. And we've had more and more instances of that coming up nowadays. But again, there are socio-cultural institutions in certain parts of the country that address intimate partner violence, which may not necessarily be the justice courts. And FIDA, we have noticed in our facility that FIDA is well nuanced in handling this because they understand the sociocultural issues and they also understand the legal issues. And like we kept on reiterating, the choice is the index client's choice, not our choice. Ours is to provide the information that they require, and theirs is to take a decision based on their circumstances. So you can imagine forcing a pregnant woman to go to court. Of course, you don't expect that marriage to continue to coexist, okay? So she would take a decision that best suits her and probably best suits her children. And most times we find out that it's a very difficult decision to make. And that is why it's not something you make for the client. You allow the client decide for themselves. At times, the family is also involved in cases of intimate partner violence. It may be just the nuclear family or even the extended family or even the community based on the social cultural norms. So that's the much I can say. I don't know whether Yetunde is on the call. I'm sure Yetunde will have something to add to this and probably Bukola too. Thank you and over.
All right, thank you very much, Dr. Eugenia, for this. I believe, just like you made reference to Dr. Yetunde, a whole lot is dependent on how our clients are counseled. There's a lot of counseling that needs to go in for couples to be able to live together and then avoid the intimate partner violence. So we have questions. The floor is open for questions now. I'd like to call on General Hospital Bonny. General Hospital Bonny, I suppose, is in Rivers State. I've enabled you. Can you please unmute yourself and ask your question? General Hospital Bonny, yeah.
Good morning, sir, and good morning, everyone.
Good morning.
I would like to ask a question pertaining this our gender-based violence, because there are some persons that do normally come to the facilities, then we do normally cancel them and take some of their data pertaining the rape case itself. But when we send the report itself, a proper follow-up is not being done because most of the rape clients that do normally come to the facility, they do normally complain. That is the reason why some of them, they are declining to come to the facility for we to take up their data and all that, because a proper and serious follow-up is not being done. So I want to know how we can go about it to a solution for that.
Okay, so what's your specific question, please?
Okay, my specific question is a proper follow-up itself. When we document all the information and the explanation pertaining the rape itself. So we need a proper follow-up when we send this data to our superiors itself.
All right, thank you very much. So I'd like to take one more question. Dr. Yetunde, I will call you up shortly, but let's take more questions and then have Dr. Eugenia respond, and then I will call Dr. Yetunde to give a perspective to where you are, that you are referred to. Let's have General Hospital Issei. General Hospital Issei, can you please unmute yourself and go on? General Hospital Issei guest, can you please unmute yourself and go on and ask your question? I have enabled you to unmute. Okay, you brought your hand down. Then, do we have questions? Please, if you have dropped your question on the chat box, I beg you to please indicate your hand, raise your hand. And if someone is asking for us to share the lecture document, you will get that So do we have other questions? If you had dropped your question on the chat box, please raise your hand and I will call you. Okay, let's have Bukola. Is it a question or a contribution?
No, I see a question from Dr. I'm going back there now. Dr. Sambo, right?
Okay, what's the question?
Okay, yes, Dr. Sambo. He said, how can we integrate IPV screening in all facility entry points with ART activities?
Someone
Dr.
is
Sambo,
asking
what I
what
would
is-
say is if you're working with IHVN,
Someone is
then
asking what is IPV. Hello?
okay, it's intimate partner violence. That's what IPV is.
Yeah, okay. I suppose you got the
Can you
answer.
hear me?
Yes, I can hear you.
Okay, so I've
Please do.
responded to that, right?
Yeah, you have.
Okay. Okay, so I see that Dr. Sambo works with IHVN. So I wouldn't want us to spend so much time because I see that Dr. Yinka wants to talk. So what I would tell Dr. Sambo is please speak to your focal person. And her name is Debbie Kalu. Speak with her, and if you still have any issues, please reach out to me. You can get my contact from the speaker. That's our ECHO lead. You can get my contact from him or Mr. John Asian. Thank you and over.
All right, thank you very much. We are ready for salvation of time. We're already climaxed our time, allotted time, but then let's just take a few questions again. If you are not speaking, you may want to just lower your hand. Ms. Bukola, do you want to lower your hand? Okay, let's have IHV and River State Program, Moses. Can we have you ask a question quickly? Moses? Moses, are you there? Okay, let's move to APIN. Okay. Mr. Moses, can you speak? I've enabled you to speak, Mr. Moses. Okay, Mr. Moses is not ready. Can we have APIN Benue State? APIN Benue State. APIN Benue State, can you quickly ask your question? Let's move on.
Good morning.
Good morning,
everyone. This is GH Boruku from Benue, APIN Benue.
Yeah, please go straight to your question.
Okay, we have a case here in our facility that we are battling with. And we decide to share if we are doing it the right way or if we are going the wrong way. Maybe we'll be helped. We have this traditional herbalist in our area that share, according to him, has been treating female from infections and fibroid. So on Monday this week, a case where one man brought in 3 of his daughters, that he took them for the man to treat them. And those ladies, according to them, when they were taken to the place, the man told them that his treatment is that he will sleep with you, and through the sleeping, he will collect what he's supposed to work with and then treat you. So when they were taken to that place, that is what the man did to them. And he treating them that if they ever told anyone or their family members about it, they will go mad and they will not marry and they will not give birth to any child. So they were not happy about it, but there was nothing they could do. So the man gave the chance to do it. So after the treatment now, then they decide to go for tests. So when they go to tests, they discover that 2 of them were HIV positive. So they were taken to the hospital here on Monday. So after the confirmation and enrollment, we advise them to bring in the medical doctor, the herbalist for test too. So when the man was tested, he's positive. It's now, the family now take the man to the police. So, and the family is not buoyant enough to even stand on the case. Yesterday, the Baba was telling me that he wants to withdraw the case because he don't have the money to sponsor anything. So what can we do? Or are we going it the wrong way? Over to you, Prosper.
Thank you very much. This is really a case of, I don't know, but let the expert speak. I don't know, Dr. Yetunde, would you want to speak on this briefly? We're already out of time, or Dr. Eugenia? It's a very traumatic one. Some person has been deceived. Dr. Yetunde, are you there? Or Dr. Eugenia, if you don't mind. Okay, Dr. Eugenia. Yeah.
Thank you very much. Thank you, Prosper. I'll start with GH Bonnie. It was a rape case, and you're asking follow-up is not done. The follow-up will be done in the facility. So I think the first question will be, who are the superiors you are referring to? When you have a rape case, the first thing you need to identify is this individual going to court with the assailant? If the individual is going to court with the assailant, then you need documented, very well documented evidence, and also collected evidence. There's a rape kit, which we do not have easily available in Nigeria, which will collect, it will collect semen if the person came to you on time. It will collect for both vaginal swabs and also endocervical swabs, okay? It will look at testing for other diseases apart from HIV that could be acquired sexually. But the problem with the rape kit is that things that you pick up immediately may not have been there, may have been there even before the rape, okay? But your documentation would be done to provide evidence for whoever is going to court to testify on behalf of this index client if they choose to go to court. Having said that, the next thing is, if the rape victim is a female and is of age and there's the possibility of pregnancy, you also want to provide emergency contraception using Postinor. The third thing is that you're providing post-exposure prophylaxis. Post-exposure prophylaxis is for a minimum of 28 to 30 days. So you do not just give the person the drugs. Remember that there may be some side effects of the drugs, okay? And you want to make sure that the person actually takes the drugs. So you would continue to be in contact with this individual while they are taking the drugs to encourage him or her to conclude the drugs for the 1 month period. And remember that your post-exposure prophylaxis, you want to make sure that this person is HIV negative before you stop. So you should also have screening for this individual done after a period of time, 6 weeks, 3 months, 6 months, okay? To be sure that this individual, even though he or she took post-exposure prophylaxis, did not contract HIV and does not need to now be treated for HIV instead of just prophylaxis that lasted for 1 month. So you don't just document and ask the client to go. There's a process and a procedure to providing post-exposure prophylaxis that goes beyond just giving the drugs, to ensuring that this person remains positive, to ensuring that whatever scenario that the person was in that led to rape is not repeated again, to ensuring that any other sexually transmitted infections are taken care of. So it's a process, and it behoves the healthcare providers in the facility to follow this process to a logical conclusion. So I would be interested to know who are the superiors that you expect to do this follow-up that you say is not done. So maybe if we have a better scenario, we'll understand you better. But for somebody who needs PEP, these are the process steps that you should take. Dr. Sambo's question, Bukola has responded to that very appropriately. In the case of GH Buruku and this herbalist, the father brought his 3 daughters. The father also took his 3 daughters there. The first question would be, what are the ages of these daughters? Are they of age? Are they adults? Are they adolescents? Okay. Are they still under their father financially, if not age-wise? Okay. So who takes decisions in this particular scenario? That will be number 1. Number 2, they have already decided to go to the police, but you did not mention when the sexual acts were occurred. Is it a month ago? Is it 2 months ago? Is it 3 months ago? Okay. Because even though the herbalist is positive and 2 out of the 3 daughters are positive, believe you me, the lawyer that the herbalist utilizes will argue that probably these girls were positive even before he had sexual intercourse with them. So it has become a legal matter. The important thing is for the father to understand what the legal process would be like, and also understand the outcomes, the likely outcomes of the legal process, so that he is prepared and he is also aware. For me, I think it was heartening to note that the herbalist agreed to even come for testing. And while you're providing treatment for the 2 young ladies that are positive, you should keep an eye on the 3rd one to be sure that that one is not within the window period. And if the person falls within the period for post-exposure prophylaxis, you should provide post-exposure prophylaxis. For these 3 individuals, you should also be looking at STI screening for other sexually transmitted infections, and treating appropriately as the case may be. For the herbalist, even though he is painted in the black, he is also an individual and should be offered antiretroviral therapy and also offered screening and treatment for other sexually transmitted infections. And here we have a beautiful opportunity to do what? Index testing. Because this herbalist is likely to lead this team from GH Buruku in Benue State to so many other individuals he has treated that may also have HIV infection. And you will be choosing with this individual whether you're going to do an approach that is client-based, provider-based, dual referral, or of course a contract referral, using your index testing strategies. So that's the most I can say within the limited time, but it's a beautiful case scenario. And I believe these are some of the case scenarios that we should be looking at, you know, for a whole session and not just as a question. Over to you, Prosper, and thank you.
Thank you very much. Thank you very much. For salvation of time, we're already very out of time. But for the for Buruku, I also want to add that based on the line that Dr. Eugenia made mention of, to actually know who is infecting who, whether it is the native doctor who also claimed that he was infected by the girls. I think one of the things that will help to address this is to reach out to your the IP supporting you. So for them to do a recent infection RTRI test to actually know whether it's a recent infection or a long-term infection. You know, if both of them can make themselves available, if you test the doctor, you'll be able to know if it's a long-term or a recent infection, and then we can also track to know who is actually infected, who actually infected who, especially for the young girls, that the 2 girls that were infected. So you may need to, I'm talking specifically to APIM Benue State, you may need to reach out to implementing partners supporting you so that they can provide you these services, recent infection testing to know where the infection is coming from. Thank you very much. We're already out of time. I would have called Dr. Eugenia for a final word. Or Dr. Eugenia, would you want to give a final word?
Thank you so much for having me present today. Have a wonderful early weekend ahead, everybody. Over and out.
Thank you very much, Dr. Yetunde. Let's have the Federal Ministry of Health give us a closing remark. Do we still have Dr. Ganiyu on the call? Can we have you give a closing remark, please?
Okay. Good morning, ladies and gentlemen. You're all welcome. Well, I wish to say thank you for attending this session of the ECHO. But before then, I would like to say that whether we like it or not, intimate partner violence is a common problem, not only among HIV clients, but also it is very common among key populations. Especially that is why the issue is well emphasized when talking about the current harm reduction program we are running currently in the country. So I wish to thank Professor Fondu for such a wonderful presentation. However, I would still like to emphasize that there is need to look at prevention, because it's a common occurrence, I've said, among the KPs, which we normally present most times at the OSS. So I will advise we look at innovative strategies on how we can see how we prevent, because the management is so complex. She made mention of issue of STI. It's not only STI. Currently, we have issue of hepatitis. They need to be screened for hepatitis. And in situation whereby somebody is positive, what happened for B and C? So these are some of the gray area we actually need to look at. How do we prevent it? What are the laws? Are the laws effective enough? What are our recommendations on how we can see that we can improve on this aspect of HIV prevention that has become an issue? So I think, and again, looking at intimate gender partner violence, we are just looking more on the physical aspect. How about the emotional aspect? It could be a form of bullying, it could be a form of blackmail, and so on, not really physical. So these are some of the sensitive areas. How do we diagnose that? How do we ensure that somebody gets a kind of relief from this? So these are areas that I think is coming on now. We need to develop a lot of efforts to see that we, address some of these concerns as related to ensuring that people will not be a barrier to people actually accessing comprehensive HIV care. As I've said earlier on, I think we need to look at the aspects of harm reduction as a comprehensive package, which encompasses, which also involve hepatitis and other areas. So I wish to say thank you, Prof. You've been a mentor to most of us. I wish to say thank you very much. We hope to see more of this kind of presentation, especially those ones that are newly evolving, as we continue to kind of provide service to community of HIV, people living with HIV in the country. I wish to say thank you very much to everyone for being part of this particular session. We are looking forward to more of such kind of discussion in subsequent weeks. Thank you for everybody.
Thank you very much, Dr. Ganiyu. So, Mrs. Bukola Adewumi, would you want to just in 30 seconds give a final word from CDC?
Yes. Thank you so much, Prosper. So I just want to appreciate everyone. Thank you so much for the hard work. Thank you so much for the great job that you all are doing at your different facilities in your different states. On behalf of the country director of CDC and the CDC management, we really, really appreciate the efforts that you're putting in place. And I just want to say that please don't wait for such platforms or opportunities before asking questions. Reach out. If you need our contacts, reach out to Prosper. If you need to talk to us, just reach out. You'll be shocked at the resources and things that are available and you can assess, you can utilize to make your work easier. So please, let's not wait until we have such meetings or presentations where we now ask some questions. Reach out to the people that you're working with, and even reach out to the partners that you're working with in your different states. So thank you so much, everyone, once again, and over.
Thank you very much. And the presentation slides and the recording will be uploaded on our usual drive. Please do yourself a favor of accessing those materials. We'll have archived materials and recordings as far back from 2020 March up until date. Every Thursday, all the materials are there. You can, my colleague Miriam will just drop it on the chat box again. If you don't have it, you can already take it from there and have access to it. Next week, we'll be looking at facility case presentation, and we'll be having CCFN present. Please, we want to encourage you to make yourself available. Let us learn from facilities next week, and then we believe that we'll take it up from there. So thank you very much from all of us here at Phase 3, my very self. I have my colleague, Dr. Azuka, Dr. Asa Daniel, Miriam Olawele, and Mrs. Asha on the call. So bye for now, and we look forward to another great time next week. Bye.